give a invite. चलो ठीक.
Yes, ma'am, start.
Yeah, it is my proud privilege and honor to be here convening this second session of Foxy ICOG Guru Mantra. And today I'm honored to welcome Dr. Bhaskar Paul, who is President Foxy ICOG, and Dr. Sheila Mane, who is the Chairperson ICOG, Dr. Ashok Kumar, who is the Chairperson-elect ICOG, Dr. Sadhana Gupta, Vice Chairperson ICOG, Dr. Suvarna Khadilkar, Secretary General Foxy, and Dr. Prateek Tambe, Secretary ICOG. We have two very eminent speakers and gurus who will be deliberating and talking on two very important subjects. One is Dr. Rajendra M. Sarogi from Mumbai. He is known to all of us, and the chairpersons will introduce him in details. And Dr. P.K. Sekharan from Calicut, who will deliberate on the subject of GTN. And Dr. Sheila and Dr. Tambe have really chosen two very great orators, and we look forward to hear from them. And I have Dr. Aruna Nigam as my co-convener, and I now hand over to Dr. Aruna to take the proceedings further.
I think Dr. Shekharan has joined.
Okay.
Dr. Shekharan has joined. Okay.
Please
So,
unmute yourself.
a very good afternoon to all of you. First of all, I'd like to invite Dr. Sheila Mane to say a few words at the start of the CME. So, over to you, ma'am.
Good afternoon, everybody. And I welcome all of you to this second event of our Guru Mantra, and really happy that all of us working together. We are working hard to see that our web series programs have started very well. And we did one in Jan, and soon we are doing in February. And very delighted to have two eminent teachers, speakers, Guru today. None other than Sir Dr. Rajendra Sarogi and Dr. P.K. Sekharan. And all of us, we know that the purpose of having this Guru Mantra is because the seniors, they are all the legends in the subject. And you know, it's very important to listen from them because their experience will teach us so many things. And it is always, we know that working for so many period of time, years, everyone tries to learn so many things, and if that has been conveyed to the younger generation through this ICOG platform, and that is why I'm very happy, and I wanted to conduct this Guru Mantra program for that purpose. And I think we have such a galaxy of speakers, you know, so we are trying to see that we really get enlightened with these speakers through this Guru Mantra program. I welcome all of you. I welcome all my GC, and thank you, Dr. Manju and Dr. Aruna, for being there as conveners to start this program, and all my GC members to be there as a chair here. So once again, good evening, and I think we should proceed with the program.
Thank you, ma'am, for such an enlightening words. So, previously there was some change in program that we are going to conduct a second session, but I think Dr. Shekharan has joined, so we will be continuing with the same way. So the first session is going to be on diagnosis and management of GTN, for which I would like to invite myself, myself, and then Dr. Shashilata Kabra and Dr. Kavita M. Bhatti. I would take this opportunity to introduce Dr. Shekharan, who is known for his work on GTN. And if you go to PubMed, you will find so many articles regarding GTN and the landmark studies related with the GTN. So Dr. P.K. Sekharan is a former professor and head, Government Medical College, Calicut, Kerala. He's the president of Kerala Federation of Obstetrics and Gynecology in 2003, and so many accolades to him. He has 51 publications with 417 citations. So, sir, without any delay, I would like to take this opportunity to invite you for this enlightening lecture on GTN, which is always confusing to many of the gynecologists. So, over to you, sir. Kindly enlighten us.
Thank you very much. Let me share my slide first. And okay.
Thank you, sir, and we welcome you, sir.
Okay. Thank you very much. And let me take my slides. Okay. The screen. Can you see the? Can you see my slides, please? Can you please?
We can see the
So you
screen.
can go
Yes,
full
sir.
screen, please.
Full screen and
Okay.
slideshow, sir, please.
Okay. Okay. Is it now? I don't know. I
No,
can't see
it's
it.
gone. Sorry, again, you have to share the screen.
Okay. 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 Share the screen. Okay.
Kindly share once again.
Okay. No, this one. Okay. Share it, not seen? No.
Sir, make it full screen, sir.
Okay. It's off
Some-
screen now?
Huh.
Okay.
Go to
Right.
You can
slideshow.
hit F5 on your keyboards.
Is it now?
Left side, left side.
Okay.
Is it okay? No, there is something that's coming there, I think. Can you see now?
Nilima,
I
guide, sir, guide where to click. That is on the left side, no, sir. There is one.
Something.
Sir, you click, double click this.
Okay.
You double click this. Now you go to slideshow
Slideshow mode, sir.
on the upper floor. Yeah, go to
Yeah.
right.
Yes.
Just below this, below.
Yeah.
Is it?
Done.
No, I can't see anything. That's why. Can you see my slides anyway?
Yes, sir.
Slideshow, sir. This is a slide, sir.
Yes, sir.
Yeah, sir. Perfect,
Something-
sir.
I think there
We
is
can
something
see you.
has come in between. Okay, thank you. Okay, sorry for all
It is
this,
visible now.
And of course, technology is very much advanced, and sometimes we may be going the same. Anyway, I must first of all thank Professor Sheila Mane, the chairperson of ICOG, Dr. Sadhana Gupta, all the governing council members, Professor Patrick Sampe, and good evening, Dr. Rajendra Sarogi, and all my delegates and listeners to this. Thanks especially to Dr. Sheila Mane for giving me this opportunity to participate in this prestigious program of ICOG. Now, gestation trophoblastic neoplasia is a highly aggressive malignancy which spread through the bloodstream to reach the distant organs within months. But in spite of this aggressive nature of the tumor or cancer, one can expect almost 100% cure in low-risk cases and up to 90% remission in high-risk cases. But in ultra-high risk, it may come down to say 30 or 40%. So this favorable outcome is because of the availability of the very effective chemotherapeutic agents, as well as because of a very sensitive tumor marker, the human chorionic gonadotropin, which is used for the diagnosis, which also tells us the volume of the disease, also is useful in monitoring the progression of the disease and treatment results. So it's a very good marker, and we are blessed with that tumor marker, which we can very well utilize to follow these cases. Now, we can see that it is, my slide is
Sorry to
not,
interrupt you, sir.
it's not
Sir,
moving.
your slides are not moving.
It's not
Light is
moving.
not moving.
No, it's not
Sir,
moving.
click on the slide.
Okay.
Now you change.
Yes, yes.
Yes,
thank you.
yes.
So, gestational trophoblastic neoplasia consists of the invasive mode, which usually present as a patient will be coming with a regular vaginal bleeding with rising HCG level, And actually, we are not making a diagnosis because we don't do hysterectomies to clinically, confirm the diagnosis. But clinically, we suspect that cases following molar pregnancy, when you see the rising HCG with irregular bleeding, subinvolutional uterus, and also sometimes the persistence or appearance of the lutein cyst later on, will tell us that it is a case of invasive mode. But to make a 100% diagnosis, you must have a tissue diagnosis, which is not necessary. In all GTN, we need not go in for a tissue diagnosis. The second one is the gestational choriocarcinoma, and then the rare types of intermediate trophoblastic tumors, which is the placenta-site trophoblastic tumor or PSTT, and the epithelial trophoblastic tumor or ETT. So this is what is grouped as the gestational trophoblastic neoplasia. The gestational trophoblastic disease consists of the benign ones, the partial and complete modes. So everything put together is the GTD, and the malignant varieties are grouped together as the GTN. Now, usually GTN is following a molar pregnancy. At least 20% of the patients who had an evacuation of the mole or who had a molar pregnancy will develop progress to GTN, mainly in the initial phase as the invasive mode. And they will present as such with irregular vaginal bleeding, the uterus may be bulky, persistence of the lutein cyst, and plateauing or rising HCG level. So this is what we call as the invasive mode, but typically there will be invasion of the chorionic villi into the muscle layer of the uterus with retaining the villi pattern, but which is not seen in the choriocarcinoma. That is how we distinguish them. So this is how what we see it as a GTN following molar pregnancy. Now, after evacuation, the regular follow-up is the key to diagnose GTN, so that single agent chemotherapy is going to be curative, and also with the minimum number of courses you can get a cure if you diagnose it at the appropriate time. So the beta HCG should be checked every week till it is negative, and then for 6 months every month. And you can, if it is all negative, then you can leave the patient, not years together, to have a follow-up. The patient will be frightened and they can be allowed to even become pregnant. The partial mole will have a very short follow-up period of once it has become negative. It is said that even one value negative after 1 month is good enough to leave that patient, but it is very, very, very unlikely to have a persistence of the disease later on. So if you want 1 or 2 values after it has become negative is good enough in a partial mole, but in a complete mole, 6 months after it has become negative. The diagnosis of GTN is not again by tissue confirmation. This is the only cancer that we treat with the highly toxic chemotherapeutic agents without any tissue diagnosis. It is on the marker. A rise in HCG, 2 weeks of 3 values, a rise is defined as more than 10% of the previous value. Just not doubling or increase, just 10% above the previous value is a rise in HCG. If the patient is having not a rise but a plateauing, means the fall is less than 10% of the previous value, is known as the plateauing level, and such values, 4 values over a period of 3 weeks. So this is good enough to make a diagnosis of GTN and start chemotherapy. And if you have the tissue diagnosis like choriocarcinoma, PSTT, ETT, they are all grouped as the GTN. Now, GTN following delivery, abortion or ectopic is diagnosed at a very late stage and may come with advanced disease. So we have to be suspecting such a situation in cases, especially in abnormal uterine bleeding, AUB. The first investigation that we have to do is the urine pregnancy test. Exclude the pregnancy complication, then only proceed with the AUB. Any seizures in a reproductive age woman or dyspnea chest symptom, you have to think of this condition and rule out that by doing a HCG. A urine pregnancy test after 4 weeks of any abortion evacuation is a good procedure because Sometimes nowadays, what we see is the patient with a missing of period, they will go to a scan report, the urine pregnancy test is positive, and the report will come something like that. You can see the picture. This is something like we will get a report that missed abortion or failing pregnancy, and the patient will have medical abortion, no histopathology, no SCG follow-up, and if it is a molar pregnancy, because molar pregnancy is diagnosed on ultrasound only beyond 9 weeks or 10 weeks. You will not see any such finding like a molar tissue in a scan before 9 weeks. So this particular case again had come to us after 3 weeks of this finding, and you can see the lower part. Now you can see that it's a vesicular mole. It's the same patient with a very increased. This is why nowadays we have to be careful. Any abortion termination, please do a simple urine pregnancy test, and if it is positive, then investigate. Otherwise, you may be missing such a situation. The top diagram can see it is not confirmed. It is not showing any evidence of molar tissue, but in the lower one, the same patient with the raised HCG, you can see. So a simple test of urine pregnancy after 1 month. Why do you keep this 1 month? So you see the graph. The time pregnancy, urine pregnancy or the Vita HCG will be negative by end of 2 weeks, the red line. In an induced abortion or any abortion, it should not be beyond 4 weeks, it will not be there. And if it is there, it is molar pregnancy or a GTN or other things. So that is why we must take this simple step to avoid such a situation, because people are now with a missing of period, they will go to a scan center, have the report as a missed abortion, may have medical abortion, and that patient is going to destined to develop a choriocarcinoma, they will develop it. So don't miss that chance. Now, management of the GTN, once you have made a diagnosis by HCG test, plateauing or rising value, you have to investigate to see the metastatic state, workup for metastasis. Minimum is pelvic ultrasonography with the Doppler, chest X-ray, if not a CT chest. So this minimum you have to do. If it is CT chest is positive, then you have to go in for all the investigations like MRI brain, CT abdomen, and other things. So initial diagnosis by beta HCG, by rising the value or plateauing, you make a diagnosis of GTN, go in for the metastatic workup. If chest X-ray is negative or CT chest is negative, stop it there. You need not go further. But if it is positive, you have to think of brain metastasis or any distant, you have to investigate fully. So that is how we have to go. The post-hydatidiform mole, pelvic Doppler, chest X-ray. If it is suspicious, probably you may do a CT chest. Otherwise, chest X-ray is still good enough. But nowadays we are going for CT chest. If the lesion is more than 1 centimeter, then only take it as a metastasis to the lungs. And if it is positive, then MRI brain, CT abdomen, MRI liver, everything has to be done. A GTN following delivery or abortion has to have complete investigation, CT chest, MRI liver, MRI brain, and everything has to be done to stage the disease and score the disease. So this is a little bit of workup. You can see the ultrasonography showing a highly vascular nodule on the uterus, chest X-ray showing a lesion there, a vaginal metastasis. So you have to work up for that. If it is GTN, then you have to do the workup to see the stage of the disease. So investigations in 2026, it has been advised that you have to go in for USG or MRI depending on risk and availability, abdomen CT or MRI, chest CT and chest X-ray as appropriate. Then if lung metastases are more than 1 centimeter, or in choriocarcinoma, contrast enhanced MRI brain and plus CT or contrast enhanced MRI abdomen and pelvis. So investigation has to be extensive in a case where you see a lesion reaching the lungs, because that patient may have metastatic lesions in the brain or liver. Until unless you stage and group the disease, your treatment may be inadequate and a cure may be missing. So the staging of figure staging of 26 which is yet to be published, is that trophoblastic tumors strictly confined to the uterus uterine corpus and cervix. In the 26th classification, cervix is also added. It was otherwise only uterine corpus. And stage 2, extension to adnexa and to the vagina or to the broad ligament. The broad ligament is added in this latest staging system. And stage 3, tumors extending to the lungs with or without genital tract involvement and with the lymph node which is seen on imaging below the diaphragm is also grouped. That is a new addition in the 2026 FIGO staging system, which may be published in another 1 or 2 months by the FIGO. And then stage 4, the gland, lymph node found on imaging above the diaphragm is grouped also as 4. So there is some addition to the staging system in the latest FIGO staging of GTN. Now the scoring system also is slightly modified. You can see instead of the 8 risk scoring factors, we consider now only 7. What is missing there in this group is the previous failed chemotherapy is not considered, because that will go as a recurrence or relapse or drug resistance. So we don't see that then. Otherwise it is the age, interval from the antecedent pregnancy, beta HCG instead of the raised to 2, 3, 4 and like that, we have put the actual value of less than 1,000, 1,000 to less than 10,000 like that, so that there is no confusion. The size of the tumor again the same, and site of this lung, vagina is given 0 and all other parts are given, some points are given, and number of metastases counted. Now the tumor on the uterus is not counted as a metastasis because uterus is the primary site. So that confusion is also eradicated now in the present classification. So there all the scoring system are to be seen. So staging and scoring is important to decide on the chemotherapy, whether it is single agent or multi-agent, decided by the stage and risk scoring. So the management of GTN depends on the stage and risk score. Stage 1, 2, 3 with a score of 6 and below is low risk. A single agent chemotherapy is appropriate there. Stage 4 or a risk score of 7 to 12, more than 7 or above, is a high risk score and has to have a multi-agent chemotherapy. Now latest one is ultra high risk, which is risk score of 13 and above. Is grouped as ultra high risk because the management is different, because if you start these patients on a multi-agent chemotherapy, there has been early death of the patient with tumor lysis and bleeding into the metabolic acidosis, so many complications are seen. So they are given a slow regime, what is known as the induction chemotherapy, and we can salvage many of these patients. Risk scoring is not applicable to PSTT and ETT. It's only stage as per the stage vision. So this is how we have to decide on the chemotherapy. Now which single agent? There were some studies telling that actinomycin is superior to methotrexate to start with. But unfortunately in these studies, more than 70% of the patients were given weekly methotrexate in compared to with actinomycin D. Now weekly methotrexate is very poor choice for a chemotherapeutic agent because in GTN, because it is multi-day therapy which is to be given either as 8-day regime of methotrexate folic acid or a 5-day regime of 0.4 milligram given for 5 days in a week and repeated every 2 weeks. So this was why, and later on it was seen that single agent to start with is methotrexate, either as a folic acid methotrexate or as a multi-day single agent methotrexate, not a weekly. So weekly methotrexate is not to be given, it is less effective, and unfortunately the comparison was between the weekly methotrexate and actinomycin D. So low risk we can give methotrexate, folic acid, you all know. The important thing is that patients should not be having any evidence of anemia. Anemia should be corrected. There should not be any infection and the count should be normal. The liver and kidney function should be normal. If you, without checking that, if you give it, the toxicity will be killing the patient, not the choriocarcinoma. So extremely careful to be checking the blood count, or the WC count as well as the hemoglobin. Everything has to be seen before starting each course. Every 2 weeks you have to do. At least the count has to be done. Renal function has to be done because the drug is excreted through the kidney and partially detoxified by the liver. So it is important to
Respected
check
sir, we
whether
have
these
1
organs are
minute left.
functioning or not. Then actinomycin D can be given as a 0.5 milligram IV for 5 days, repeated every 2 weeks as an alternative drug. You can choose whatever is there. So multi-day methotrexate is used as a first line therapy, followed by actinomycin D if they don't respond. Weekly methotrexate, again NCCN guideline has said that should not be given in 2019. Now, it is seen that low risk score of 5 and 6 are not responding to single agent very well. Even though it's a low risk group, the group 5 and 6 may not respond. But it was thought that you can still give them that low risk because 40 to 50% of them will respond to single agent without risking to the toxicity of multi-drug regime. And those who are not responding will respond to the multi-agent therapy later on and get a 100% cure. But now we have a little bit modified it because we have seen that better that in cases of score 5 and 6, if there is a histological confirmation of choriocarcinoma, or if the pre-treatment SCG is more than 400,000 and above, or with a metastasis anywhere, especially lung, with a SCG concentration less than 400,000, but is 150,000. Still, in such cases, better to start with multi-agent chemotherapy upfront rather than the single agent. So, in a group of risk group of 5 and 6, you modify it in these conditions, start with the multi-agent therapy. Rest of them can be treated with a single agent to get a cure. That is how you divide the grouping the patient to whether to receive single agent or multi-agent. High risk 7 to 12, it is a IMACO regime. I don't want to take the time of, you can see that it is a multi-agent very toxic drug, but up to 6-7 courses we can give. So in single agent low risk cases, you can, once it has become negative, we can give 2 to 3 consolidation courses. In a high risk patient, once it has become negative, you may have to give minimum 3 consolidation courses after it has become negative. Now, ultra high risk, we said that it is a group with a risk score of 13 and above, usually with extensive liver and brain metastasis, and it was reported early death due to sudden tumor collapse and bleeding, metabolic acidosis, septicemia, multi-organ failure. These were the results of when they were treated with the multi-agent therapy. So it was decided to start a gentle therapy with than full dose of multi-agent therapy, which is known as the induction chemotherapy. It is etoposide 100 milligram per meter square and cisplatin 20 milligram per meter square on days 1 and 2, repeated for 2 or 3 weeks. Once the patient is stabilized, you start with the full course, usually in this patient platinum-based multi-agent chemotherapy, because they are most of them are having liver as well as brain metastasis. In brain metastasis, you have to add more of methotrexate or give radiation to the brain. Now, PSTT and ETT are less sensitive to chemotherapy. They are more amenable to surgical treatment if it is in the early stage, and it is possible to have lymphatic spread. So, it is not a routine to go in for a lymph node dissection, but cases of high risk PSTT or ETT, which is stage 4 or interval between from the last pregnancy or a pregnancy event is more than 48 months, they do very badly, and they have to give an aggressive multi-agent therapy, resection of the possible metastatic sites, and try to get a lesion. So these cases are not very easy because they are not diagnosed early. And this is one of the cases of early PSTT where we can stop with a hysterectomy and add a cure. So PST10 ETT are less responsive, but you may have to multi-agent. So we are having very rarely situations of multi-drug resistant as well as recurrent GTN. And in 2017, it was reported that anti-PD-1 agent like especially pembrolizumab is quite effective, and out of 4 cases, 3 could get complete remission. And later on, there were almost 100 cases now reported. These agents are going to be effective in such difficult cases to get a cure. So we are trying to get more and more of cure of this patient. As such, is early diagnosis and starting treatment is appropriate treatment, is getting very good result, but there are cases up to 10% in the high risk group and about 50% in the ultra high risk group who may not respond easily. And such cases, we are hoping to get this immune checkpoint inhibitors to get a cure, and hoping to get 100% cure in all our patients. So this is in summary. If I am stopping it here, we can have discussion there. Thank you very much.
Yes. Thank you so much. Thank you, sir, for that enlightening and comprehensive talk on gestational trophoblastic neoplasia. Your clarity in explaining its diagnosis, risk stratification, and management has greatly enhanced our understanding of this important subject. And the few points in your talk were very good. First, a simple UPT test after 4 weeks after any abortion. And then today I came to know about the new FIGO 2026 classification. And it is to be noted that the cervix had been included in stage 1 and the broad ligament in stage 2. And sir, your WHO FIGO 2026 classification is simpler and less confusing. Thank you so much. May I invite Dr. Kavita Bhatti to speak something?
I think Dr. Kavita has not joined.
Okay.
Yeah, she's not there. So if any questions are there, no, I don't think there are any questions in the chat box.
We can proceed with the next session. We'll take
Yeah,
the questions
definitely.
at the
Definitely.
So
Dr.
sorry,
Shashi-
actually,
Dr.
I just joined. I was busy somewhere else. I'm very sorry. I'm Dr. Kavita Bhatti.
Yeah. Dr. Kavita, you can conclude the session with your remarks.
No, I missed the lecture actually, Dr. Aruna.
Okay. Okay, no problem. So,
Let's
Dr.
carry on.
Shankran, it was a wonderful lecture, and really GTN is quite confusing sometime, but you have given a very good insight into it and also given the latest updates on the same. So thank you for joining this for this talk. And with this, we end this session and proceed with the next session. Yeah, ma'am.
Chairperson, I
Please.
want to discuss one case. Sir, it is always great to listen to you, and we always have looked forward since a long time. I have one case to discuss. The patient had DNC, vesicular molar pregnancy, at some hospital, good one. And she is having, it is almost 1 year, she is having low HCG level always. It is around 200, sometime reaching up to 1000. Ultrasound is perfectly okay. She is also okay. But when she has taken methotrexate like for 1 or 2 or 3 months, then we thought that we will only follow the patient. But when we stop methotrexate, it is rising around 300, 450. And she is 40-year-old. And I'm really don't know that hysterectomy will like improve it or not improve it. Lung metastasis is okay. She is fine. So what's your opinion about that?
First of all, we have to see whether it is a real HCG, what is going on for the last 1 year or so in spite of the treatment. And the patient is clinically well as per the assessment. Now, if it is, sometimes we may have very rarely HCG hanging around, which is not a real HCG. And in which case, you have to check the urine. And this is what is known as the, wrong reacting agents are out into the circulation, like animal proteins, and it will tag onto the HCG assay systems. If you go for the urine pregnancy test, it will be negative if it is false positive
Sir, it is weekly positive. It is always positive.
The weekly positive is
During
the
pregnancy.
difficult situation. You have to really see it and see what it is. And urine pregnancy test is. Other thing is do it in dilution. If it is real HCG, as per the dilution, if it is twice dilution, it should have half value. It will really. The other one will have FSRD. It will go. It will not come down also even if you dilute. So dilution. And you have to really think, because she was given methotrexate, there can be sort of what is known as the quiescent GTN. Without activity of the tumor, there will be HCG at a lower level, but at a later stage, the patient will have really the malignancy will be blowing out. The drug is not effective because it is not dividing cells. It is only on the dividing cells the chemotherapy will act. So it will go to a quiescent stage. HCG will be there. She is otherwise okay. The tumor will not be increasing. There is no symptom. But later on it may flare up. So she has to be on follow-up. So these are the three things that we have to see, and exclude sometimes pituitary HCG. You can give 3 courses of oral pills if it is due to that after doing other things. So the pituitary HCG can also confuse the issue. If you give oral pills for 2 or 3 cycles, it will come down. So 3-4 methods of diagnosing it and going about it. Otherwise,
Thank you, sir.
There are
And
2 questions for
does
sir in the chat
hysterectomy will
box.
help it? Sir, does hysterectomy will help the patient? Because
Which one?
she is worried. Hysterectomy will help the patient.
No, hysterectomy is not the answer until and unless we have a diagnosis. Just because you can do a hysterectomy, that may not be correct. So you have to know what it is.
Thank you, sir. Thanks a lot.
Dr. Aruna, there are 2 questions in the chat box. We may take one.
Yeah, definitely.
Yeah.
Kindly
You
take up.
can take, Shashi, no problem. We have
Sir, there is one question. After molar evacuation, first week beta HCG 7 lakhs, histopathological report H-mole, no retained product, how to go, pre-evacuation beta HCG 25,000.
Okay, you have to see that it is coming down or not. You have to repeat the test. The beta HCG follow-up is weekly till it is becoming negative. So what is the trend? If it is within 2 weeks, if it is rising, it is GTN. And you start investigating for metastasis. If it is stage and the risk score is low, you start with a single agent. What we prefer is the methotrexate folic acid. So go about that way. It is definitely, it is something like mathematics. You have to know if it is so, how to work up and other things. It is all very well defined. So to say, it is easy to make a decision, but there are very, very difficult situations we have come across. So this is the patient has to be whether it's a plateauing or rising value, diagnose GTN, go for the imaging things. If it is not there in the lungs, you can stop it there and start it as whatever the score is to be done. As per that, you have to have the scoring system on your table. Circulate, give 1 point, 2 point, 3 point accordingly, and then calculate whether it is 5 or 6 or above 6. Above 6 is multi-agent. Above 13 is highly aggressive type of a situation. So it can go reach anywhere. But luckily, following molar pregnancy, we make a diagnosis at an early stage where single agent will be effective. I hope it is clear.
Thank you, sir. Dr. Aruna, you can move forward.
Sir, I have one question, Dr. Shashi.
Yes.
Now, suppose we have a case of molar pregnancy and we have done the beta HCG values.
Yeah.
So is there any guideline that suppose even if, we have done that and if it is more than 2 lakhs, we must give some chemotherapy like methotrexate or something
No.
if the values are high?
It was there because it was still not out of question. What we call as the high risk mode, in the sense that they may develop more risk of developing, and the patient is not going to have a regular follow-up. You think that she is not going to come. She is in such a social situation, and it is a high risk. Once you get more than 1 lakh before evacuation, it's a high risk condition, or a patient who is elderly, or the size of the uterus is more than 4 weeks of the period of amenorrhea. These are some of them. But we have never given prophylactic chemotherapy for such cases. We were evacuating and following them. Our follow-up was, I can claim that it was better than the Americans or from UK, because
That's great.
what you have to do is, you have to little bit serious, because you have to be telling them 80% after evacuation you are going to be safe. But who is the unfortunate 20%? We do not know. And this 20% is going to develop something like a cancer. You have to put across that word cancer without frightening him, but they will get frightened. So that is the way of getting them for a regular follow-up. We are not really frightening, but you have to frighten them. Otherwise, they will take it lightly, and we may get a patient who is coming late. And accordingly, you can follow them and stage the disease, score the disease, give the correct chemotherapy. So personally, I have followed more than 1,500 cases of molar pregnancy myself. Means our team, when I was there in the college, and later on they are doing it. So far at Calicut Medical College Center, we have never given any prophylactic chemotherapy. We have never missed a case of GTN by following up. Our patients are not very rich, they are also poor, and even though we claim that we are all literate, there are people who are illiterate also in between. So they are all coming, and they are a good set of sitting. We have to tell them, we have to be sitting with them, telling them, a group of 50 patients and their relatives, you have to tell them this is what it is, you are having an abnormal pregnancy. It is 15-20% chance of going for something like a malignancy. But if you come regularly, we will pick up at the earliest possible time. With the minimum course of chemotherapy, you will get a cure. You can conceive and have more children. So in this group, there will be people who had chemotherapy, alopecia, and who had chemotherapy. After that, they have conceived and coming with the children. And this situation, people are very much convinced about what you are doing. So that is how we have done the
Excellency.
thing.
Sir, one suggestion. Now, so many missed abortion cases we see.
Yeah.
So as you showed the ultrasound,
Yeah.
so there is a chance that we can miss the diagnosis there.
Yeah.
So is that, and nowadays we have medical abortion.
Yeah.
Is it is it better that we do a surgical evacuation and send the tissue for histopathology in missed abortion, we have to get a beta HCG levels done?
That is not acceptable to the public. How can it be acceptable to the public? They can, if it is just an abortion, they can have a medical abortion. So what we can do is, you can give one more week. If the HCG is falling down, it is more towards a failing pregnancy. If it is normally progressing, it is going to be a normal pregnancy. If it is doubling, going up like anything, as in that particular case, from 2,000 it has gone to lakhs in 2 weeks' time. That is a molar pregnancy. So those cases, because other cases, simple abortion, if you say surgical evacuation, it is adding on to the workload and people will not accept it because it is so easy to have the medical abortion. But what I said to us, at least ask them to come after 1 month, have a urine pregnancy test done. You will never miss it. Unfortunately, fortunately, it has come in the UK guideline. After in this group, I was arguing this way many times, and it has come. So, as you know, once I am arguing with a conviction, I am arguing like anything. So it has come like this. So it is all easy.
Sir,
Yes.
what were the common metastatic sites you had observed? What was
Lungs.
the most common site?
Lungs, madam, lungs.
Okay.
Even not vagina. It is not vagina. It is lungs. Always lungs. So that's why in our group, because once a result has decisions come, it is unanimous. But I was always arguing for lung metastasis should be given additional score there. But now they added the lungs with the beta HCG level, you have to take it as multi-agent therapy, even though the risk score is 5 and 6. So lungs is the commonest, and it will reach lungs within 4 months. That's why the duration of for more than 4 months is given an extra point. So that's why I said it's an aggressive disease that way. It progresses so rapidly to reach. It's spread through blood. Even though it's a carcinoma, it's spread like a sarcoma through the bloodstream. And it evade perforate the blood vessel and go everywhere and cause bleeding.
Thank you,
Yes, sir.
sir.
Thank you.
Thank you, sir.
So,
I think we
thank
have
you.
had a good
one last
interactive.
question, Dr. Aruna, if I can ask.
Okay.
Actually, just had a patient some time back with a coexisting normal pregnancy, but she was in the first trimester, so we went ahead with MTP. So, what is your take on that? Can we continue such
We
pregnancies?
have to rule out that you have to rule that, I mean, find out that it's a normal pregnancy. We had a pregnancy referred to us as a partial mole at 14 weeks. But see, looking at the scan, we could see that it was separate from that. The normal looking placenta and the baby was separate. So we did that 3D scan, and once it has become 16 weeks, we did a amniocentesis. It is normal karyotype, continued with the pregnancy. Luckily, after 28-30 weeks, the molar tissue started regressing and the beta HCG was not going up. She had a normal vaginal delivery, a female girl, and it was a complete. The other one was all, there's no time, otherwise I could have shown that picture also. So we can continue. It's a wanted pregnancy for the patient. If she wants that, it is her child.
Yes.
And you have to be careful. With the risk, we have to tell them the risk is at any time she can have very severe bleeding. You have to have operative delivery at any time. All those things have to be counseled. Luckily, in our case, she had a vaginal delivery.
Thank you.
Okay, sir.
I
Thank you
think
so
we
much.
can
Thank
have
you.
a
Yeah.
we can have this session closed. Otherwise, we are not going to leave Dr. Shekharan. Please be there because people are not now going to put their questions in the chat box. So you all the delegates can put their question on the chat box and sir can answer there so as to keep up with the time. So thank you all the chairpersons and the Dr. Shekharan. We move to next session, which is on the hysterectomy, difficulties and challenges in vaginal hysterectomy. And for this session, I would like to invite Dr. Manju Puri. Everybody knows very well, Dr. Anita Rajoria and Dr. Sanchita Dubey. So I will request Dr. Anita Rajoria to kindly introduce the speaker. Dr. Anita, are you there? Dr. Anita?
If she is not there, I can do
Yes.
the honors. Dr.
Okay.
Rajendra Saraogi is a legendary teacher of teachers. He was my teacher almost 30 years back. In 97-98, I was his registrar at the Cooper Hospital. His dexterity of fingers, sharpness of wit, and the legendary memory that he has. He remembers every single student who has passed out under him for almost 40 years. He's simply unmatched. May I present to you Dr. Rajendra Saraogi?
Yes, sir, you have been lucky, Prateek, sir, to be trained by him. To formally introduce Saraogi, sir, he is Emeritus Professor, State GS Medical College, ex-honorary HOD RN Cooper Hospital, Mumbai, Senior Consultant,
I think,
Nanavati
Anita, we can
Hospital.
stop at that.
Yeah. And sir is a very great vaginal surgeon. I have seen his videos, sir. It's always a pleasure to learn from you. Over to you, sir. Over
Thank
to you, sir. Is going to talk about challenges we can face during vaginal hysterectomy. Over to you, sir.
Thank you,
Sir
Anita.
is one of the few people who does Shauta's vaginal hysterectomy, the radical hysterectomy as described in the textbooks, and it's a treat to watch him.
Oh, okay. I think it's a real treat, Prateek.
Next slide, please.
Yes.
What is more important is whatever surgery you want to do, remember the Hippocratic oath, first do no harm. Next, please. Root of hysterectomy, the need of hour is to maximize effectiveness and safety of therapy with the least disruption to women's lives. There should not be any pain, early discharge from the hospital, early resumption of activities, no scars, minimal scars, and lower cost. Next, please. We know vaginal is almost always extraperitoneal. We can have abdominal, we can have LVH, we can have TLH, we can have robotic surgeries. These are the various routes of hysterectomy. Next, please. Various types of hysterectomies which can be performed are subtotal, partial 2/3 of uterus removed, total with salpingectomy, with salpingo-oophorectomy, panhysterectomy, radical hysterectomy, and finally caesarean hysterectomy. Next, please. Now look at this picture. This gives you an idea. If you look at the first picture, it is abdominal hysterectomy. When the uterus is removed for similar indication, most invasive. Then comes vaginal, which is supposed to be the least invasive. And then you have LAVH, that is laparoscopic assisted vaginal hysterectomy, moderately invasive hysterectomy. Next, please. What does Cochrane review say? Route of hysterectomy. Among women undergoing hysterectomy for benign disease, vaginal hysterectomy appears to be superior to laparoscopic hysterectomy and abdominal hysterectomy as it is associated with faster return to normal activities. When technically feasible, vaginal hysterectomy should be performed in preference to all the other surgeries possible. Next, please. What is more important for us to understand is vaginal hysterectomy differentiates gynecologists from general surgeon. If you go to PHC level, you will find general surgeons performing hysterectomy, but they will never dare to perform vaginal. They'll do TAH or they'll do LAVH. VH is scarless surgery, LAVH is minimal scar, and TAH is scarred abdomen. Next, please. Today, in most countries, over 20 to 50% of births are carried out by LSCS. This figure may rise in future. It is therefore conceivable that surgeons of tomorrow will be confronted by the need to carry out hysterectomies in women with 1 or 2 cesarean sections. Women who have not delivered vaginally and have had LSCS are vaginally nulliparous and abdominally parous. This is my terminology. Hence, every hysterectomy should be considered for vaginal approach unless there is a contraindication. Luckily, with passage of time, indications have increased and contraindications are gradually decreasing. Next, please. Generally, the ratio of vaginal hysterectomy to abdominal hysterectomy varies from 1:3 to 1:4 or less depending on the country. We want to reverse this ratio. Next, please. All laparoscopic surgeons freely acknowledge that the laparoscopic route is being performed only to convert an abdominal procedure to a vaginal one. With inclination and effort, the ratio of 3:1 abdominal to vaginal hysterectomy can be reversed. Next, please. What affects the route? Now let's come to the basic idea. How can you decide whether this can be done vaginally or abdominally or it requires laparoscopy? First and foremost, most important thing is mobility and descent. If there is freely mobile uterus and descent is there up to the introitus, yes, vaginal route is the best route. If there is uterus-free space adequate to maneuver the instruments, think of vaginal. If subpubic arch is normal, again think of doing vaginal. Cervix normal size and length, again think of doing vaginal. Fibroids, if accessible location, please think of doing vaginal. And surgical attitude, trained, enthusiastic experience. This is where all the problems come, where people are thinking in terms of doing abdominal hysterectomy or laparoscopic. The reason why people don't want to do vaginal hysterectomy is basically with the idea, I have never done it. That is the first thing. If you ask them, have you seen? Yeah, rarely we have seen. That's another thing. Third thing, suppose I try and if I don't open the pouch, then what will happen? Fourth thing is, suppose I can't deliver the uterus out, then what will happen? Fifth thing is, suppose bladder gets open. I personally feel all these fears which are there in your mind has to be removed before you think of doing a vaginal hysterectomy. Next, please. Why a vaginal hysterectomy? Have you thought I started my practice in 1980, almost 46 years back? That time, whatever instruments I had purchased, the trolley, the table, the light, everything remains same. But if you think of doing laparoscopic hysterectomy, you require all these gadgets which are there and which will keep changing. That's the most important thing. Next, please. Scoring system for vaginal hysterectomy. This is very important for us to understand the feasibility of doing vaginal surgery. If there is mobility of the uterus, 1 mark is given. Narrow vagina, if you can put 2 fingers, again 1 mark is given. Uterine size is less than 12 weeks, 1 mark is given. If endometriosis is absent, 1 mark is given. Removal of adnexal masses, no masses, 1 mark is given. If no LSCS has been done, 1 mark is given. If there is no puckering of POD, again 1 mark is given. So minimum score should be 7 before you think of doing a vaginal hysterectomy. Safe score is 7 to 11. Moderate risk of conversion is 12 to 16, and high risk is more than 16. So you should keep in mind about these factors which are important, the parameters which I have mentioned just now. Next, please. How to decide route of hysterectomy? Sonography plays a major role. How many times have we bothered to find out the volume of the uterus when we send the patient for sonography? We hardly ask them to write the volume. Volume is very important when you send a patient for sonography. Normal volume is less than 100, which is easy. Average gynecologist should be able to do it. If the volume is between 101 to 200, where the uterus is less than 8 week size, interested gynecologist should be able to do it easily. If the volume is between 201 to 300, the uterine size is 9 to 12, best performed by a gynecologist with expertise. If the volume is 300 to 350, the uterine size is 13 to 16 weeks, needs debulking. And if the volume is 401 to 500, uterine size becomes 17 to 24, where you can give trial of vaginal hysterectomy, may require debulking, and may consider LAVH in these cases. Next, please. So other points as far as sonography is concerned is it helps in differentiating between fibroid and adenomyosis. It gives you various dimensions like size, number, degenerative changes, etc. in a fibroid. It also gives you an idea about presence of adnexal masses. It rules out malignancies, the space on both sides of the uterus. What is more important is at times we may encounter abnormal position of the kidney or back pressure changes on the ureter. Endometriosis is present and various sites it can be located. Next, please. It gives you an idea between adhesions between uterus and the surrounding structure. It can give you an idea about congenital anomalies of the uterus. You may come across uterus diadelphys also. What is the most important thing is angle between lateral cervical surface and ascending uterine wall of the uterus. Smaller the angle, more difficult is the vaginal hysterectomy. So if it is less than 90, don't think of doing a vaginal hysterectomy. Next, please. What are the various contraindications for doing vaginal hysterectomy? If it's a malignancy, unless until you have done Schauter's hysterectomy, or if you are trained in Schauter's, you can think of doing CA cervix operation. Otherwise, avoid doing vaginal route. Disease primarily in the adnexa, again avoid doing vaginal route. Inaccessible cervix, particularly if it's flush, short, or displaced with restricted descent, again avoid doing. Excessively narrow vagina, virginity, nulliparity, unless until you are well trained, don't think of attempting to do a vaginal hysterectomy. Uterine size is more than 12 weeks or 16 weeks, or there is associated broad ligament fibroid, avoid doing vaginal hysterectomy. Past surgery like cervical amputation, Fothergill's repair, sling repair, ventrofixation, VVF repair, etc. Don't think of attempting to do a vaginal hysterectomy. Next, please. Give me reliable finding of EUA and I will give you an unambiguous decision on the route of hysterectomy. These are Dr. Shirish Sheth's words. Next, please. Favorable findings under examination under anesthesia, absence of any contraindication, mobility of uterus in all planes, uterine descent, adequate free pelvic space around uterus, uterine size and volume as we mentioned earlier, free vaginal mucosa around the side of the both bladder and rectum, normal cervical length of portio vaginalis. Next, please. Let's come to traction test. If this is by Dr. Shirish Sheth himself. If traction on the cervix with a Valsalon is applied to the anterior and posterior lip separately and leads to a finding of external os remaining above the ischial spine without any descent, then this is not a suitable case for vaginal hysterectomy. Similarly, there is dimple sign by Dr. Shirish Sheth. A retraction of the posterior vaginal wall of more than 1 centimeter diameter Adjacent to the site of pouch of Douglas, when the cervix is raised using a valsalum, indicates ovarian endometriosis, or there can be pouch of Douglas endometriosis, which has resulted in obliteration of pouch of Douglas, making the surgical access challenging for the surgeon and risky for the patient, and thus contraindicating vaginal hysterectomy. Next, please. Cervicofundal sign by Dr. Shri Sheth. Again, this is basically based on the principle that if uterus is stuck to the anti-abdominal wall, maybe due to previous cesarean, what will happen? You won't be able to see the cervix on introducing a large speculum along with the pulling up of the posterior vaginal wall. It signifies uterine adhesion to the anti-abdominal wall, seen mostly in women who have undergone previous abdominal surgeries. Again, please avoid doing vaginal surgery. There is something like trial of vaginal route, like trial of labor. We can do a trial of vaginal hysterectomy, taking the patient into confidence that we are trying for vaginal. If we succeed, fine. Otherwise, we can go ahead with laparoscopy, or we can go ahead with total abdominal hysterectomy. We have pneumosurgical pack which can be used to ensure the contents of the pelvis, particularly the intestines, are kept clear of the surgical field. The pack is inflated by compressing an attached bulb and self-retaining and removable. Next, please. Difficult situations during vaginal hysterectomy. Access to anterior pouch. Sometimes in cases with previous caesarean section, opening of the anterior pouch may be difficult. However, we have to understand one thing: whenever we do caesarean section, the bladder is adherent to the central 3/5 portion and not to the lateral 1/5 on both the sides. This non-adherent portion of the bladder can be easily approached for separation through Said's uterocervical broad ligament space as a surgical window. Familiarity with this space helps in easily finding out the vesico-uterine fold of peritoneum and the anterior pouch. Same principle we apply at the time of doing abdominal hysterectomy or even laparoscopic hysterectomy. Next, please. In some cases, the uterus may be very bulky, hence difficult to deliver vaginally. In these conditions, one can do debulking operation. It is required when all accessible tissues have been cut and no further uterine descent is possible. A uterus is with the volume of more than 300 ml requires debulking. Debulking of a larger fibroid is easier as compared to many small fibroids. It is attempted only after the uterine arteries are ligated. This is the most important thing which you should keep in mind. Posterior uterine wall is easier to debulk than the anterior uterine wall. Next, please. Next, please. Coring, that is also called as lashes procedure. This is best suited for removal of smoothly enlarged globular uterus of moderate size. This is very useful when vaginal canal or subpubic arch is narrow. With strong cervical traction, the outer myometrium beneath the uterine mucosa is circumferentially incised. By this, an enlarged uterine fundus delivers as an elongated sausage-shaped mass. It is something like what we do during laparoscopic laparoscopic assisted hysterectomy. Once we have removed all the adhesions with the uterus through laparoscope, when we deliver that uterus vaginally and it's big in shape, same we get sausage shaped mass. It is the same thing. We have hemisection of bivalving. The cervix is held with clamps at 3 o'clock and 9 o'clock position, and traction is applied using a knife. The cervix is incised anteriorly and the posteriorly. The incision is carried up to the uterine fundus, thus splitting the uterus in two halves, and then it becomes easier. Mind you, what is more important is all these things to be done only after ligating the uterine arteries. Next, please. If there are small fibroids, you can do myomectomy, you can do wedge morcellation. Next, please. Then there is systemic anterior morcellation called as Prioros technique. Then we have posterior fundal morcellation. Then we have cantonment and enucleation. These are various methods of morcellation. Next, please. Other modalities to increase the vaginal dimensions. You can give episiotomy. You can give Schuchert's incision. Schuchert's incision generally I have given at the time of doing a CA cervix Schauter's hysterectomy. Cervical amputation you can do. You can apply suprapubic fundal pressure. You can do laparoscopy also and help you in doing vaginal hysterectomy. Next, please. Post-operative packing. Now, these are controversial thing which I am going to talk because I believe in using the pack post-operatively. Many people don't believe. I believe in putting a pack and it eliminates the dead space, gives rest to the bladder, acts as a hemostat. Pack should be removed 24 hours after surgery, and after removal of the pack, spotting is normal after 2 weeks. Next, please. Another point is giving post-operative vaginal douche. I don't know how many of you are giving douche, but I believe in giving douche. How many of you have had dental extraction? Mind you, when you have dental extraction, what the dentist advises you is go and do frequent gargling. Why? Same principle is applicable. No, come back please. Same principle is applicable to our vaginal surgery. Potentially infected cavities like oral cavity and vagina are exposed to the exterior. Antibiotics, antiseptic pessaries can be inserted. Prevent infection as blood clots are washed out. Blood always works as a good culture medium. It prevents agglutination of the vagina. I remember as a houseman way back in 1975 to 77 when I was a resident, my bosses never allowed us to do any speculum examination, do vaginal hysterectomy, send the patient home and call them after 6 weeks. And we have seen agglutination of the vagina where anterior and posterior vagina wall are adherent to each other. Next, please. This douche will help you in early diagnosis of anterior vaginal wall hematoma. It removes unhealthy tissue with hydrogen peroxide and antiseptic solution. Mind you, vagina is always healing by secondary intention. And any secondary intention healing requires unhealthy tissue to be removed, and this is the best way of helping in healing. Urinary leak can be detected early, infection can be diagnosed. It helps in early mobilization of the patient, can find out source of bleeding per vagina. I believe in giving douche on 3rd, 7th and 15th day, and finally the pack is not missed. Next please. So the various advantages of vaginal surgery are natural route familiar to the gynecologist. Same instruments can be used for generation. No incisional hernia, keloid formation, tuberculosis or endometriosis I can add. Good for all high risk patients. Very good in all cases where abdominal mesh has been put. Least morbid, most rapid post-operative recovery, less time consuming. Next please. Lesser learning curve, reduce hospital stay, no painful abdominal incision, lesser postoperative infection, paralytic ileus, less postoperative adhesions, cosmetic, less tissue trauma. As per Doyes, no one could call himself a gynecologist until he performed vaginal hysterectomy in private. Next, please. Now, these are the differences between vaginal surgery and laparoscopic surgery done under regional anesthesia where spinal is given. This is done under GA with all possible tubes and gadgets inserted. Next, please. The anesthetist is relaxed here. Anesthetist is tensed with eyes constantly on monitor watching. Next, please. After seeing this, I am getting the famous Bollywood dialogue from Chulbul Pandey. I will make so many holes in your body that you will be confused from where to do what. Next, please. If you don't find anything on the machine, either he is gone or the net is down. Next, please. Position of the patient is slight Trendelenburg while it is steep head low. Next, please. You can see a Sirshasan position in these cases of laparoscopic surgery. Next, please. Short learning curve, even a first gynec poster gets a chance to do it. Long learning curve, teaching done after post-graduation only. Next, please. It's a conventional surgery, cheap and meant for masses, while laparoscopic surgeries is unconventional, very expensive, meant for elite class only. Next, please. Can be performed easily in high-risk cases. Various prolapse repairs like AP repair, posterior colpoperineuropathy, SUI repair can be performed. Laparoscopic surgery is difficult to perform, particularly with incisional hernia and previous abdominal surgeries. If at all, foreign material may have to be put. No pre-operative preparation required. Assistant only 2 nurses are sufficient. While here pre-operative preparation is required, many assistants are required. Many people are required behind the scene monitoring gases and other gadgets. Next, please. Here you can see the patient feels I'm feeling like I'm watching IPL. Next, please. Can be performed in rural area in camps where electricity is a problem. Time required is much less and surgeon is comfortable sitting on a stool. Here, no, it requires a modern theatre. Time required is much more. Neither surgeon nor assistants are comfortable. Next, please. Complications are much less. No gas is put, so no question of pain at the shoulder, abdomen, no air embolism. Here it is much more. Next, please. Next. Next. Please inform all your visitors that a videotape of your endoscopy is available in the gift shop. Next, please. Have you something suitable for my husband's endoscopy photo? Next, please. A good physician treats the disease. A great physician treats the patient who has the disease, as mentioned by Williams Hostler. Next, please. Let's accept the fact that vaginal route is always the preferred route. If you can't access vaginally, then you can take help of laparoscopy, and if that is also not feasible, you should resort to abdominal surgery. Next, please. We gynecologists should not fall prey to gimmicks, gadgets, and glamour and subject our patient to surgeries such as laparoscopic hysterectomy, which may be associated with high risk of iatrogenic complication. We all know about ureteric injuries, etc., etc. Next, please. We should promote and propagate vaginal hysterectomy, which is indigenous surgery, natural surgery being performed through natural hole. It follows our PM Modi's mission of Make in India. It is like an Aam Aadmi surgery. Next, please. Time has come to conduct learning courses and workshop all over India, just like laparoscopic surgery workshop, in order to remove fear and misconception about vaginal hysterectomy. Friends, what is more important? The forceps vacuum and episiotomy are becoming extinct due to rising LSES rates. Similarly, vaginal surgery will also become extinct one day. Next, please. Next. Next, please. Thank you. I take this opportunity especially to thank our ICOG chairperson, Dr. Sheila Mane, my great friend, Dr. Pratik Tambe, Vice ICOG chairperson, Dr. Sadhna Gupta, and all the big faculties which I can see on screen. I'm so grateful to all of them for listening to me. Thanks a lot. Thank you. Thanks for giving me such wonderful opportunity to talk in front of you.
Thank you, Sarogi sir. Thank you for those nice messages and encouraging words. Every gynae person who is passing out, doing post-graduation must be familiar with vaginal route of surgery. Of course, they can gradually change over to more difficult cases. Initially, they should do normal size uterus or uterine descent surgeries for vaginal. Then they can graduate onto much difficult surgeries, as you talked about, large uteri, difficult, access. So we should always do a good examination under GI, as rightly suggested by you. It will tell you so many things, whether your vaginal hysterectomy will be feasible or not. And it goes without saying, sir, I must admit that while you are taking consent of such patient, you should take a consent that, okay, means trial of vaginal hysterectomy will be done, but if not possible, the patient may likely be opened up. We should not feel ashamed of that, and we should counsel the patient properly. tell her about everything, what are the possibilities, and the decision to take laparotomy should be discussed with the patient earlier only. We should not scare the patient as such, but of course we should counsel that sometimes we may need to change over to abdominal route. Thank you, sir. Thank you for those nice messages and your scoring system and how to predict the feasibility. That is very, very great. Thank you so much. I request Sanchita to add on to my comments.
Yeah, thank you so much, sir. It was such a pleasure going through your presentation, and the way you have made it so precise that the first thing is case selection, examination under anesthesia, then how to proceed with the steps. It was wonderful how to tackle the different cases, and I think being gynecologist, vaginal surgery should be our forte, and we should not leave it. Secondly, as you correctly said, 15-20 years back, we were not so comfortable with laparoscopic surgery. So we used to have extra training for that. So now we should, emphasize on extra training for vaginal routes. And in all PG courses also, these should be encouraged so that we don't hesitate in taking a decision about the vaginal surgeries. And I feel if we get expert in that, then of course, that's so simple. You have enumerated so many advantages of vaginal route over laparoscopy and the abdominal route. The perfect one was the initial picture which you said it's an intact door, and then the door all shattered and multiple holes in the door. So that is, I mean, that slide says everything about the vaginal route of hysterectomy. Thank you so much.
Thank you, madam.
Sir, thank you, sir. I think as Dr. Pratik mentioned, sir, sometime we would like to see the video of Chauta Mitra's operation because, I mean, I'm also a student of those days where we used to learn about Chauta Mitras, okay? Now we know that different techniques, but we will definitely have a video session, Dr. Pratik, and I think that time the rarest of the rare surgeries, I think we can really show. So thank you, sir.
It's a wonderful surgery, madam. It's a wonderful surgery. I'll tell you, once you'll see Chauta, stop thinking of doing any other malignancy surgery for CS cervix.
Okay, so definitely, sir. I think Dr. Pratik mentioned about it, and I think those who are attending today will be really eager to see that. I think Dr. Ashish is here, Professor.
Yeah, Ashish.
Yes, Ashish. I think you want to say something. Yes, Ashish.
He's a wonderful teacher. I can tell you that much.
Sarogi sir,
So
people want to know. People want to know what thing you are using for giving douche to such patients post hysterectomy.
Yeah, it's a good question. What I do is I put in a small speculum, pour hydrogen peroxide, give a wash with saline, and then pour betadine. I'll tell you, when we were residents and when I became an honorary and professor and all that, so many cases where we used to give spinal, for giving a douche, patient was moved to go to the table, and we realized that patient has got paraparesis.
Oh.
So many cases of missed pack we have removed on third day when patient was taken for douche. So such things are quite common.
Yes, sir. We were also trained to give douches, but those were the selected cases, and we started suspecting some kind of infection or so. But it was a routine practice at that time, sir. I'm talking about 80s. But recently, people have foregone with this. So I think it's a good idea, sir, to give douche. Yeah.
I personally feel since 77 till now, almost 49 years, I have been giving douche to all my vaginal surgery cases.
The vaginal pack and the vaginal douche are the good old days. The old ways still work even in modern times.
True.
Dr. Saraswati, my regards to you, sir.
Dr. Ashish wants to ask, yes.
Yeah. Sir, I am a great fan of yours.
Oh, thanks.
And what I liked in your presentation is simplicity, humor, and all those good things, as Pratik is saying, are coming back. And we are one of those people who used to practice all these things.
Correct.
Still practicing. And I just want to ask you this hysterectomy scoring.
Yes, sir.
I mean, this is a very good innovation, and I think we should all follow this. And particularly for the young gynecologist, I think there is some message by Dr. Saraogi is that erstwhile EUA, examination and anesthesia, is very, very important a tool for a gynecologist, because we are still practicing this and we wonder whether we are backdated or not. Because this EUA works so well and it gives us such a lot of information that I salute you and Professor C. Sheth about this, rejuvenation of EUA. I think I am inspired by this, and I will teach my students also henceforth about EUA.
I think, Ashish, you said it rightly. Those days, ultrasound was not there.
Correct.
So examination under EUA used to be the main thing before the patient was posted for hysterectomy.
Absolutely, ma'am.
Yeah. And the doubt, as sir said, yes, I think that reduced the incidence of sepsis also, the walled sepsis and everything post-operatively. Yes.
Madam, I'll
betadine cleaning before taking the patient up the previous night. That is one practice which we still follow even today, which has sometimes fallen out of favor in some units.
We can even give betadine pessaries 1 or 2 days prior to the surgical procedure for every hysterectomy, because anyways vagina is going to get open even if we are doing laparoscopy.
Madam, you're talking about betadine pessary. I have seen betadine pessary being put between two thighs, not in vagina.
Thank you, sir.
Dr. Sadhana wants to ask something. Yes,
Sadhana, एक minute. I wanted to take your opinion, sir. What we usually practice in hysterectomies, before going into hysterectomy, we always used to prescribe Metrogyl tablets for 2 to 3 days before the procedure. Do you recommend this, or do you do this?
No, I don't prescribe Metrogyl tablet, but I definitely give Metrogyl once I have done the hysterectomy.
But I do this, Dr. Ashish, because most of the time, if they have this vaginal infection, bacterial vaginosis, then the walled sepsis is common in them. So usually pre-operatively, anyway, the patient will be admitted. The patient is in the ward, So it's better to give them pre-operatively when she is undergoing the preparation. That even. I think Dr. Manju Puri wants to ask, and Dr. Sadhana.
Yes, sir.
First, Dr. Sadhana and then Manju. Yeah.
Thank you, Dr. Sheila. It was really, really treat to listen to you, Dr. Rajan. And just I wish to share that I am alumni of SN Medical College, Agra, where we have stalwarts of the vaginal hysterectomy, Dr. Ramesh Chandra, Dr. Naval Kishore, Dr. Varun Sarkar, Dr. Arun Nagrat, and how beautifully we completed all difficult cases with this almost slicing and something. But what I really, really appreciate that this is Guru Mantra, and sir, you have that courage to point the fallacies of the laparoscopic hysterectomy, which is very technically, economically demanding for all the things. And when our generation, what is a generation X or Z is, where actually the commercial forces are making so much loud voice.
Correct.
That we are simply missing a very, very simple procedure, which is like a part and parcel right from our first year residency or MBBS days. What is the vaginal anatomy? So I think that is the message which we need to propagate. Do use technology whenever it is needed, and a rigorous pre-operative preparation. And it is not that minimally invasive that as it seems to be. So this is something really what we can say a sanct voice in a lot of trash noises, and it was simply great. So
thank you,
we look forward to Dr. Manju learn from you.
Dr. Manju.
Yeah.
Ma'am, you're mute. You need to unmute yourself.
Yeah. Thank you, Dr. Saraogi, for a very insightful talk, very simple messages, and conveyed in a very simple manner. So as far as the antibiotic regime is concerned, I personally, feel, and what we do is that we definitely give 2 grams of tinidazole prior. Because bacterial vaginosis is one thing which does give rise
Can't hear you, madam.
She's in
I
a
think she's
transit, so
traveling,
she
so
must
there's
have
some
lost the
network issue.
network. Yeah. Okay.
I'll suggest two things.
Thank you.
I am thankful to SOSI. I don't know how many of you are member of Society
Sir,
of
we are,
Vaginal
sir.
Surgeons of
Sir,
India.
we started Karnataka chapter. Dr.
Yeah.
Sushila Rani is here attending and she's very happy. Okay. And
I'm really thankful to Dr. PC Mahapatra, Hara sir, and now Dr. VP Paili for
yeah,
helping
so
me.
we started Karnataka chapter just last week.
Okay.
And
Second
we had
thing-
almost 250 people attending from all over Karnataka.
Excellent. Second
And they
thing
became
what I-
members. Yeah.
Second thing what I have started in Mumbai is anybody who wants to do vaginal hysterectomy, I go and assist them and I don't charge them. So they have that feeling ki, okay, let's try it out. And once they try it out, they get more encouragement to go ahead with doing vaginal
I
hysterectomy.
think Dr. Manju, you can ask now. Again.
May
Yeah.
I?
Yeah, so basically, it was just trying to find out as to what antibiotic, would you use, Dr. Sarogi?
I give antibiotic in the form of ceftriaxone, sulbactam combination for just 2 days, 48 hours. That's all. Along with either tinidazole or metronidazole.
But don't you think giving pre-operative antibiotic would be more useful than giving post-operative antibiotic? Because all what sepsis gets in would be at the time of surgery, no?
I do agree with you, madam, but all my private patients, they get admitted 1 hour prior to surgery.
Right.
So to ask them to get admitted becomes difficult, you know.
But
When I
anything
was
given
one line, ma'am?
when I was
30 minutes,
for years,
yeah.
I used to give because there they don't mind getting admitted 2 days prior to surgery. In that case, we used to start tinidazole and not oral. I used to give IV because orally once I give, they start vomiting, then they'll not like the surgery also.
Right. But I think we all need to reduce the antibiotics which we give and move on to, antibiotics with lesser resistance, keeping in mind the WHO aware, classification of antibiotics, wherein the third generation cephalosporins are in the watch category. So we do develop resistance faster to that. So we should reserve them for actually indicated situations. So just a submission from my side. Thank you. We thoroughly enjoyed your talk.
May I add one line, ma'am?
Please do.
Yeah. Saravgi sir, it was an excellent lecture, and like you, I am also a strong proponent of vaginal hysterectomy, and I always tell my students that whenever a hysterectomy is required in any patient, think of first performing a vaginal hysterectomy unless proved otherwise.
Very good. Excellent, madam. Superb.
Thank you.
Thank you to the organizer who have done a wonderful job in organizing this. Excellent. Superb. And special thanks to Pratik for inviting me just 2 days back.
Sir, thank you,
Thank you, sir.
Thank you for accepting. And I thought that some senior person only should give all these tips, sir. And the way you have given the tips are so important. And I think still it is learning for us because day before yesterday, as I said, that I had missed that there is a big myoma. But I did it, sir. I didn't give it up, The anesthetist and the nurses was telling, madam, you should have done it laparoscopically. I said, nothing doing. I will do it. You don't worry. I'll finish it.
I have one suggestion for all of us. Before you wash up, in a vaginal surgery, always give position to the patient yourself. That is first suggestion. Adjust your sitting table, the stool which you sit, adjust it yourself. The light should be adjusted by yourself. And not only patient's bladder bowel should be empty, even your bladder bowel should be empty so that you are more comfortable operating. Thank you. Thanks a lot.
Thank you. I think, Pratik, you can do the vote of thanks. Yeah.
Thank you, ma'am. So, as the Secretary of ICOG, it's my proud privilege to present the formal vote of thanks for the second episode of the ICOG Guru Mantra, my gratitude to Dr. Sheila Mane for initiating the previous episode and this episode also with two fantastic, legendary, eminent stalwart OBGYNs, namely Professor Shekharan for GTM and Professor Rajendra Saraogi for vaginal hysterectomy. We had two conveners today who have done an excellent job, and 6 chairpersons, all of whom are drawn from our ICOG Governing Council. Many of them are newly elected ICOG Governing Council members. Thanks to them for all the hard work and coordination behind the scenes. Thanks to our ICOG office staff, Nilima, Poonam, and Shreya at the back end for doing the honors and coordinating the program very well. And last but not least, I need to place on record my gratitude to the audience. At one point, I think we had more than 200 people simultaneously logged in. Even now, I see that there are more than 100 people, which shows that academics is central and core to our ICOG message. And more of ordinary OBGYNs need to join in and benefit from this entire series, which has initiated in a fantastic fashion with so many wonderful academic messages going out. So thank you again, everybody who joined. Thanks to everyone. And in case I have failed to take any names directly, then the fault is entirely. Until next time, goodbye, God bless, and see you all.
All of you, please join on 19th for our master class, which is going to be on Mullerian anomalies. Again, we have selected a faculty who are the expert in this field. And I think month end, we will have a certification course on endometriosis. So I think Pratik, from next time, the program which we do, we can just put one slide, in the bit in
Yes,
between.
ma'am, we can do that.
Yeah, so that
Yeah,
those
I
who
think
are
the
watching
flyer
also
should be
will.
ready by Saturday. So we'll start
Yeah.
disseminating the flyer early so that we have more
Thank you.
attendance of the
Yeah.
master.
Thank you all.
Thank you very much, ma'am. Thank you, everybody. Goodbye. God bless. Bye for now.
Yeah, recording will be available on ICOG website. So everybody can, okay. And thanks to Dr. Sekharan, he has to catch a flight tonight, but I requested him to join because I thought that he is, they have a lot of experience. So once again, I thank both Dr. Sekharan as well as Dr. Saraogi. Thank you.
Thank you, madam. Thank you.